Welcome to this session. There is going to be a change. Mr. Robert Milligan will speak first, and then it will be followed by the other session with the speaker, Mr. Hadjopoulos. It is true that nowadays we encounter a lot of non-palpable lesions that we have to localize in order to excise them correctly, that is, excise the whole lesion and have a free margin as well. Hook wire localization has served us breast surgeons for many years, and it continues to do so. But modern technology gives us several devices nowadays that promise to help us surgeons as well, our patients, and make our lives easier, and at the same time provide us with a good oncologic result. But what are these devices and how do they compare with the golden standard localization method of hook wire? Dr. Robert Milligan, our distinguished guest speaker, will talk about this subject. Mr. Milligan is a consultant oncoplastic breast surgeon at Queen Elizabeth Hospital in Gateshead, UK. Besides being a breast surgeon, oncoplastic breast surgeon, he has a great experience in devices localizing non-palpable lesions, and in fact is the first surgeon in United Kingdom to introduce the RFID tag localizer system. Mr. Milligan, we're all ears.
There. It's a great honor to be invited back to come and speak to you again with regard to non-wire options for breast surgery. So we know that the world is going wireless. These days, it doesn't matter what you do, whether it's charging your mobile phone or listening to music, playing computer games. There are so many options where the world now has removed the wires to make things easier to function in life and to help with the ergonomics of just surviving and enjoying leisure. And breast surgery is no different. Over the past probably 10 years or so, there has been a move towards going wireless, removing the guide wire. And the guide wires have been around for many, many years, so introduced in the 1970s. And as you rightly said, they've served us very well over that period of time. They've given surgeons an option to at least find roughly where in the breast a target area is. And ever since breast screenings come along, we've found more and more areas of disease or potential disease that requires surgical excision and therefore needs localization. So we're going to talk today a little bit about guide wires themselves, just to see where we've been and then where we're heading to. And as you say, there's a number of different devices on the market now, and every year or so something new comes to the market. So it's a very evolving space, and it's worth keeping on top of that because we have multiple options now where we can choose from. So the simple guide wire involves a hollow needle and a wire, usually with hooks or barbs at the end. And essentially the hooks and barbs start off inside the wires inside the needle. This then gets retracted back and the needle is placed percutaneously towards the breast lesion. This can be done by ultrasound scan or stereotactically. The needle is then placed through the lesion, passes just beyond the lesion, and the wire is then inserted, usually by the radiologist, and this will put the hooks which deploy just beyond the lesion, then the needle is retracted and the wire then comes out through the skin. So this is a pretty good way to find out where the lesions are in the breast, and pre-guide wire was very difficult. You know, this type of surgery didn't really exist for non-palpable lesions. It was complete guesswork if you were trying to take out an area and didn't know where it was. As we've moved towards breast conservation surgery, particularly for the impalpable lesions, the guide wire was a godsend. It was a great thing to allow surgeons to conserve the breast, which, as we know from the 70s onwards, was really a time we started to do that. So there are multiple benefits of having a guide wire, but equally, it's quite primitive and quite basic. So for the patient, it's not an ideal thing. And for the surgeons, which we all are here, it's not great. The guide wire can limit you in terms of where your incision is, because you have to factor in that there's a wire coming out the skin. And as we move towards oncoplastic surgery, you want to make the incision ideally in a cosmetically sensitive place rather than straight over the tumor. Guide wires can travel for a long, long distance inside the breast, where you see a mark where the wire disappears into the skin. And then beyond that, you have a couple of views on the mammograms where you know roughly where the wire is going to be. But this is on a compressed breast, so it doesn't give you a true idea when the patient's lying flat as to where the lesion is. So armed with a surgical finger, we can palpate the breast and we can have a poke here and there and see where the wire moves, and we have an idea where it is. But ultimately, where the tip of that guide wire is, we don't entirely know. And it's not uncommon if you do a guide wire resection that when you're dissecting down and you think you're beyond the wire, you actually come across the wire itself. So we just don't quite know where the tip of the wire and where the tumor is. So we're it's helpful, but it's not perfect. So there's multiple benefits from it, with it working very well for so many years. It's cheap, it's easy to insert. And radiologists potentially, if they insert the wire, say stereotactically, and it goes into the wrong place, for multiple types of wires, they can then retract it and reinsert it. So these things are all very, very beneficial. Every radiologist in breast surgery knows how to insert a guide wire to localize a tumor. But it does require coordination with the radiologists and the surgeons. So on the morning of surgeons, patients need their tumors localizing. And this can lead to delays in the start of the theatre list, and it may impact with the radiology clinics. It doesn't work so well if radiology and surgery are on separate sites. So sometimes patients, if you have radiology at one site and the surgical centre elsewhere, the patients may need to have their tumour localised in one place and then travel with a wire sticking out of their skin, but usually bandaged up, across the city to the other hospital to have it removed. And patients don't like it. It's an anxiety-provoking procedure. They may be sitting all day with a wire in their breast. It can be uncomfortable, and they're already anxious on the morning of their surgery. The other thing, because the wires stick out of the breast, and you often will wrap these in a bandage or a dressing over the top, there's a chance that they can become dislodged in the hours while they're waiting for their surgery. So there was a problem, there was a market need. So then wireless localization techniques have come in. And these generally involve small implantable devices. And they're inserted in a similar way to post-biopsy tissue marker clips. The beauty of non-wire techniques is we can decouple the radiology from the surgery. These things can be inserted generally well in advance of surgery, up to the morning of surgery if necessary. The morning of surgery is okay, but it takes away some of the benefits of the fact that we've decoupled radiology and surgery. Generally, we see it's better for patients, and they can have a separate outpatient appointment, so there's less anxiety on the day of surgery, one less thing to be done, and they can even be brought in later on in the day at a time that is more suitable for their procedure. The patients obviously can't see these once they've been inserted, and the vast majority of these can be inserted at the time of biopsy or prior to neoadjuvant chemotherapy. Any of the techniques that we'll discuss allow real-time distance measurement to the lesion, so you know exactly where in the breast that tag or seed is lying and where the tumor is, rather than a guess by, or best estimation by, palpating the breast with a finger. And generally, these can be used in the breast and the axillary lymph nodes, like guide wires can be. But they are more expensive. And that's a big thing when it comes to any health system. The people with the money, the managers, say, well, what's wrong? Why don't we use the cheapest thing out there? So having a business case and some evidence behind the change is an important thing. So there's multiple different types of techniques now, and we have choice. From having no choice with the guide wire, we have choice. And a brief look at the different types of systems we have. Initially, we started using in the UK radioactive iodine seeds back in 2015, I think was when we introduced that. Following this, magnetic seed, so the mag seed became available, and then radio frequency ID tags with the logic localizer. Since then, there's the radar reflector, Savvy Scout, and the Sirius Pintuition, which are all available now in the UK. There are some units which still use ROLL, so radiocult lesion localization, where technetium is injected around the tumor site, and then the tumor can be excised using the gamma probe. And carbon staining for lymph nodes can be used as well, although I'm not aware of it being used to detect breast tumors in the UK at least, but certainly in some countries this may be the case where finances are more stringent. So a brief look at radioactive iodine seeds. So this uses iodine 125 encased in a titanium capsule. And these are very small seeds, 4.5 millimeters in size, and they're injected through an 18 gauge introducer. Multiple lesions can be targeted, and you can use this in the breast and the axilla. The difficulty with this is that any sealed source of radiation requires multiple regulatory issues. And if you lose one of these seeds, then in the UK, it's the RSAC, which is the regulatory body for radioactive substances, will close down the department until it's been found or until a root cause analysis has been taken. So these are very good, they're cheap, but they're an absolute pain in order to use in case you lose one or it gets sucked up through the diathermy suction or lost in the patient. So they haven't really taken off despite being a good way of identifying the tumors. I think there's a lot of hassle associated with them and paperwork. So most units now have moved towards non-radioactive alternatives, which now exist. This is the first paper that we wrote showing that they were safe to use in the UK. The mag seeds came on the market next, which uses paramagnetic steel and iron oxide seeds in order to localize the tumor. And again, a very small 18 gauge introducing needles used. They're non-radioactive, which was a big step forward, taking the radioactivity out of the seeds. These can be placed up to 25 millimeters apart. Their depth perception is approximately 40 millimeters on the probe. And in some cases, surgeons have reported that despite palpating the breast with the probe and pushing the probe into the breast before incision, they can't always identify where that seed is, and sometimes need to make an incision to go to roughly the area of the tumor, and then the probe should pick up the seed at the time. Some surgeons will use a guide wire for this reason, if it's a particularly big breast or the tumors in an extremity of the breast, and that's certainly the case in some of the units, and these can be used very safely in the axilla. The induced magnetism from the probe means that any iron-based instruments can disrupt the signal. So plastic surgical instruments are recommended, or no instruments and just fingers when using the probe. The probe itself is relatively large in comparison to the other alternatives on the market. MagSeed is safe, but there is a large bloom artifact, which you'll see with many of these devices. So paper here written showing that MagSeed is safe, a safe alternative to guide wires, showing good resection margins. And in the UK, the IBRA was an organisation set up to look at these technologies and evaluate them. And from each of these, which we're looking at all of the different types available of seeds and non-wire markers, we're doing these studies and always have a shared learning at the end of it, where all the people that have input cases We'll show the problems, and then the people with the most experience in these have a shared learning session to say these are the issues that were found and this is how we can overcome them to improve the use of them in all of the different options available. Radio frequency ID tags. So this is the hologic localizer, which I'll be talking about a bit more today. It's an 11mm RFID tag, so it's a bit bigger than the alternatives we've spoken about, and inserted through a 12-gauge needle. There's multiple benefits to this system, including the fact that each radio frequency ID tag has a unique ID number. And this means that if you put multiple tags in the breast, you have that ID attached to each of those tags. So to each tumor, if you remove a tumor in one area and there's a B3 area elsewhere, or the lateral edge of the tumor, you can identify which is which. And none of the other systems have that currently. So you can't always be certain if the same tag when you're listening to the signal and looking at the distance to a tag, you can't be certain in more complex cases with multiple of these tags in place. If there's no unique ID, you can't be certain that you are listening to the second site, not the first. And it can become complex occasionally in more difficult cases, such as therapeutic mammoplasties or areas of big breast conservation. There's a good depth detection here of up to 60mm, and again, no radioactivity. You can use standard surgical instruments, which is very helpful. And the probe is incredibly small, as is the handheld reader. So the other systems have quite bulky units that require to be placed on a trolley. This is just handed over, you hold it in your hand, and I'll show you some pictures of that later. And we've written papers on this. So this was our first 150 cases in the UK, which we'll discuss in a bit. The main issues with this is the device diameter is fairly large. So large needles are needed, bigger than the other systems, in order to insert the tags. And it can be difficult to insert into some dense breast tissue. It's not currently got a license for use in the axilla, but it is safe to do so. And we'll discuss that later and our results a bit further on in the presentation. Again, these can be used in MRI, which isn't an issue, but from a bloom artifact point of view, we've shown here in one of our cases about 35mm of bloom artifact. So if you put them in prior to neoadjuvant chemotherapy, an MRI scan is your modality of choice to assess for tumor response, then it's not ideal. So these are usually best placed after neoadjuvant chemotherapy, once there's been the post-neoadjuvant MRI scan, or alternative to MRI scan, such as ultrasound scan, if that's what you use. In the UK, we tend to use an MRI scan to assess response, so we tend to put them in afterwards. Savvy Scout is radar reflector technology. So there's a small central unit measuring 4mm and then some longer antennae on either side. It's a small introduction needle, and you can place it in multiple lesions up to 40mm apart. There's approximately a 60mm depth detection, similar to the RFID tags. They can be deactivated by electrocautery. So if the diathermy current hits the antennae, then there are reports that the system then becomes defunct and you can't identify where it is in the breast using the probe detector. There are some possibilities or difficulties in detecting this if it's deep in hematoma, and that's certainly been reported. So some of the surgeons will say, look, put them at the side or anterior to hematoma if there's a big hematoma after vacuum biopsy for calcification. And again, there's been multiple new papers on all of these devices showing that they're generally all safe. Probably the newest to the market is a Sirius Pintuition, which is a permanent magnet and gives a real-time distant measurement like the others from the probe to the small seed. These can be inserted 180 days prior to surgery across Europe. In America, the FDA had this at 30 days, but I've just seen that has been improved and increased now, and they can also be used and licensed in the axilla and lymph nodes. And again, there's been studies to show that these are also safe. So these are the main devices which are now available on the market, certainly across Europe, and things that if you can afford are there to use. And there's a fair amount of evidence for each of them, but that evidence is growing for all of them. And we've discussed pretty much the pros and cons briefly of all of these. And a big thing is that apart from the radioactive seed localization, we're avoiding radioactivity in each of these. They can all be used in the breast, they can all be used in the axilla, and they can all be used prior to neoadjuvant chemotherapy, but there are some caveats. So the big question, which device is best? Well, my opinion is it's a bit like choosing a car, and you ask 10 different people, they'll give you 10 different answers as to which is best. And it's not for me to tell you, but what I will say is I think they're all better than our trusted guide wire, which has served us well for a long time. And occasionally you may need to use, but really there are better options available these days. So I'm going to talk about our localizer, our experience with the Hologic localizer since we introduced it in 2019 in our breast unit. So this is how small the probe is. So there's a handheld reader which will identify the tumor from the radiologist's perspective without the sterile probe. And just in the circle at the top there, you can put that over the breast and it will give you a real-time reading of how far the tag is from the tumor. From the detector. There's a small probe which, compared to a biro pen there, is very small and the smallest on the market by far, which is one of the things that's attracted us to it in the first place. And we'll talk about the paper here with 150 cases that we used in our breast unit. So the first 150 cases were all discussed at our MDT meeting. We used resection margins according to the Association of Breast Surgery of England margins, 1 millimeter for invasive or DCIS, and we performed further surgery where appropriate for re-excision or mastectomy. So 177 tags were inserted into 150 women. Average was about a week before surgery, and these patients were all in their, well, the mean age was in their 60s, and the vast majority were screen detected as expected. As this was our early experience, the vast majority were inserted via ultrasound rather than stereotactic. So only 4 at the time were stereotactic. And part of this is because with guide wires, you can often retract these if they're in the wrong place. And stereotactic insertion is something that when the breast is compressed, we see it with biopsy clips and we see it with these devices, that they may end up in a different part of the breast or moving along the tract when the breast is released from the mammogram machines. So we still would always preferentially use ultrasound to locate our lesions where we can, but we know for things like calcification, there's times when you need to use stereotactic localization methods. So 174 of the tags were deployed successfully to the target lesion. 3 of those were misplaced. So 1 tag early on migrated along the tract at the time of deployment, and a second tag was deployed. And we think that was that it just wasn't properly, the needle wasn't properly depressed at the time, and the tag just stayed in the back of the needle rather than anything else. There was another tag which was slightly anterior to a lesion, and as we were early on, the surgeon decided that they were more comfortable with having a guide wire in addition. In reality, if you know where the tag is in relation to the target lesion, being a couple of centimeters away from it doesn't actually make too much of a difference in my experience. There was another tag that was inserted stereotactically, and it's just lateral to an area of calcification. So a second tag was put in and the lesion was bracketed. But again, if it's not a particularly big area of calcification, I think you can have these lesions placed at the side. And as long as you know if it's sitting medially or laterally, you can adjust your resection in order to account for that. Some difficulty was noted by the radiologist in inserting the introducer into dense breast tissue or into the center of fine masses. Surgical excision was relatively straightforward. All the tags were located and retrieved. On occasion, tags which were placed superficially within the lesions were identified during dissection of the tissues. And it's very important when you start dissecting the tissues that you do have the probe and identify as close as you can where the tag is, and usually stick a marker stitch. If you get within a centimeter or a few millimeters of where the tag is, it's always helpful to put a marker stitch or a pen mark on that tissue in case you have a problem where your device becomes sort of inactive, such as the Savvy Scout or the RFID tag, if it becomes loose and dislodged. So our results, we did the majority of these were for wide local excision. Some cases were with volume replacement and some therapeutic mammoplasties. The types of cancers were a typical split between ductal and lobular cancers. Our margin re-excision rates were 6.7%, and 2 patients went on to have completion mastectomy. So that was an 8.7% re-excision rate, which for us was about half of what we had when we used guide wires. So we knew that localizing lymph nodes, which we do for targeted dissection, we were doing that with guide wires, wasn't licensed in the RFID tags. But we felt that it was safe to trial it and see how we would manage. Bearing in mind, we put it into similar sized tumors as the lymph nodes within the breast and had no problems. We were using guide wires as this technique in the past for localizing lymph nodes, and that was unlicensed. So our hospital was happy to let us introduce this as a new procedure, and we collected our data of our first 75 cases, really as a feasibility study to see if these could be used for lymph nodes. And there was a lot of concern prior to it from certainly other people that didn't use it, that the device was too big and it wouldn't work for a lymph node. So we looked retrospectively at the data, which was carried out to analyze these first cases between the 12th of June 2019 and October 2022. We deployed 75 tags into the axillary lymph nodes, and there was a 100% success rate there. 62 of these tags, so 83%, were lying directly within the lymph node on ultrasound scan, as you can see in the picture. So the third on the top, which is the X-ray pictures after retrieval, and the ultrasound pictures in the middle. 13 of those tags were lying directly adjacent to the node, so they were either in direct contact, which was the vast majority, or slightly away from the node, and the maximum was 8 millimeters away from the target lesion. All the tags and nodes were successfully excised at the time of surgery with no significant complications. There were 4 cases where the tag was dislodged during excision, but this didn't compromise retrieval of the tag or the node. It was often on manipulation. So we concluded that the RFID tags were safe to be used for the preoperative localization of lymph nodes, and this was proved safety and feasibility, which hopefully should help with the licensing of this. So we had a few lessons that were learned. When patients went down on the morning of surgery for guide wires, we would often get a packet back with a sheet showing where the guide wire was in the breast, so some diagrams of the mammogram pictures essentially. And when they weren't going down to the unit, we needed a sheet still, so we've created a sheet which just shows where the localization is in relation to the lesion, and this gets placed onto our computer system alongside the mammograms so we can access it in the operating theatre. From a radiological perspective, the tags were very easy to insert. Passing the introducer through dense elastic breast tissue and firm tumours could be challenging, but it was often achievable through increased persistence and pressure, and twisting of the introducer could help. Certainly the patients didn't ever have any issues when the radiologists were struggling to insert it into deep tissues. The patients had no problems from an anxiety point of view, and none of the procedures have ever had to stop. Occasionally, a compromise has to be made with the deployment where it's placed adjacent to a lesion if it won't go in, and it's likely to be overcome with a smaller device or introducer. So the radiologist will put the tag into the lesion, and if they put it straight in, it can bounce back. And this is a common phenomenon. So the technique to use instead is to insert the lesion the tag a bit further into the lesion, and then deploy it as the needle's being moved backwards. We aim for at least 30 millimeters apart for lesions inserted in the same breast, and there's sometimes some positional considerations, such as with stereotactic needle or localization of the tags. If the breast is compressed, these lesions can end up quite close together in the operating theatre. Overall, we've seen a very short learning curve for this type of change in localization. We've had great patient feedback. We found the unique tag ID very useful in identifying separate lesions in axillary lymph nodes. The specimen handling and pathology requires no special precautions. The pathologists like these because they easily come out of the lesions, unlike guide wires, which can be fixed depending on the type of barb used, and they're not sharp, so the pathologists don't have to worry about stabbing their fingers on them. They're easily disposable. They can be thrown away in the clinical waste, and it was really helpful for multi-site operating, which we had during the COVID-19 pandemic. But no significant procedural difficulties or complications related to the tags since we started using them 4.5 years ago. And we've found them perfectly good to use in the breast and axillary nodes. It's a small, robust and ergonomic system, and the tags have now fully replaced guide wires in our system. We certainly have no regrets having introduced it. So we know that they're safe, and we use them for both breast lesions and axillary dissection. Where next? So the eyebrow net is looking at a questionnaire. So they did one in 2020, looking at what people across the UK were using, and the vast majority were on guide wires. That's been redone recently, showing that essentially many more units now have moved away from guide wires, which is a trend we're seeing sort of certainly in the UK, but Europe-wide and worldwide. We have done the survey, which I spoke about, and that's gone out recently, should be published soon. There's a localization study, which is looking at all of the different types of devices, and we're just due to publish the localizer soon, as we did with the Magseed in the past. And from a European point of view, Eurobreast and EyebrowNet have put together the Melody study, which is looking again at different devices to try and show the differences with resection rates and all the pros and cons of the devices to get a bigger body of evidence. So if you are using any devices and want to be involved, and get in contact with the Melody study, they should be able to enroll you for cases, which has just started now. So it's open for recruitment. So please feel free to get in touch. Thank you.
Dr. Milligan, thank you very much for your detailed presentation. I think you made it very clear that guide wires are already obsolete. There's a huge international experience with the newer modalities. I think most of them are available in our country too, but the cost still remains a concern for us. I personally am more familiar with the roll technique, and I find it much, much easier, so I confirm that guide wires are already should go away, and we should try something more modern, more efficient. But we hope that the cost goes down so that we can use it more often and get more familiar with these newer techniques. As it is a sponsored lecture and we're running out of time and we're already late with the program, we will accept no questions or any other comments from our audience. And I would like to thank you for being with us today. Thanks a lot.
Thank you.
Thank you.